Hi everyone. We've just started the webinar so that those of you who are tuning in early can check the volumes and make sure that everything's working over your side. We'll keep it open for another 3 minutes before we actually start the webinar, which is at 6:30. It will be interesting to see how many will be joining live. The weather is definitely amazing, and I'm sure a few will be tuning in to the recorded version later. But we are expecting a bit of a crowd tonight, so hopefully be a few joining us live. So we got another 2 minutes before we're going to start the webinar. We just had a few more people join just then. So I'll just repeat, we've just started the webinar so that those of you who are joining us a bit early can get everything sorted, get comfortable. You still got another 2 minutes before the webinar actually starts at 6:30. So if you want to go and grab a cup of tea or get that dinner, you still got a bit of time. And then we're going to start off at 6:30, and we'll probably be here for a little while, but nothing longer than an hour. Just seeing a few more are joining. So we still have another minute before we're going to start the webinar. This is just your opportunity to check that everything's working over your side, that you can hear us, that the volumes are all good. And we will kick off in about a minute, probably a little less now. So 6:30 is the starting point. We just had a few more join, so that's really fantastic. It's amazing to have you all join us live. We know how hard it is to juggle everything that we have on our to-do list, and it's always a nice thing to be able to listen to this live. It is a big difference to the recorded version. So thank you so much for making the effort. So we got just under a minute left. If you do need a glass of water, now is the time to grab it. And the time has just ticked over. So we're about to start. So I'm going to get all the speakers of tonight to turn their cameras on. So we've got Myles and Elisa joining us. Hello. Welcome everyone who is joining us live to Understanding Diabetes Self-Management Principles. This is our second webinar. So we had our first one last week. So for those of you who are new this week, I'll just want to mention that this webinar is being recorded. Now, before we begin, I'd like to acknowledge the traditional owners, past, present, and emerging, of the many lands that we are meeting on today. And I would like to also extend that to any Aboriginal or Torres Strait Islanders participating in the webinar tonight. My name is Linda Carlson, and I'm the communications lead here at Diabetes Tasmania, and I will be your host tonight. So for those of you who joined us last week, we have some familiar faces. We got 2 speakers, but 3 different topics that we will be covering tonight. So first up, we have Myles Fletcher from Diabetes Tas. He will talk to us about how to support your patients to manage their diabetes and some useful resources. Then Elisa Williams, also from Diabetes Tas, will talk about some practical tips around insulin. And then finally, Myles will finish off talking about continuous and flash glucose monitoring, and he'll also do a demonstration of how one of those machines works. So really looking forward to that one. And so everyone's visible at the moment, but as soon as we start the presentations, only the presenter will be visible. But don't worry, we're still here. And with that being said, actually, we also have the Q&A function enabled throughout this webinar. So if you have any questions throughout the talks, post them in the Q&A, and then whoever is not speaking will be able to answer questions throughout the talk. And then, of course, at the end of each presentation, we'll have some time to go through the Q&A, and the press center themselves will do that one. We also have the chat function in the corner there. So that one is mostly for us. We will be using that one to post useful links and other resources that the speakers might be talking about tonight. And before I move on to presenting or handing over to our first presenter, I'd just like to mention that this webinar is being funded by the NDSS. So NDSS is the free Australian government initiative for people living with all types of diabetes. And the NDSS provides support services, information and subsidized products. So NDSS is administered by Diabetes Australia, and Diabetes Tasmania is your state agent. And I just want to point out that it's really important for us to register all our patients on the NDSS. The Australian government uses statistics obtained through the NDSS to identify the number of people in each state and territory with diabetes. So by registering all your diabetes patients on the NDSS, the government has a more accurate idea of the number of people living with diabetes. And this is really important because this in turn affects the amount of government funding allocated to our work, and also the percentage of funding that we receive in Tasmania. So with that being said, I'd like to hand over to our first speaker, Myles, who will talk to us about diabetes self-management principles and resources.
Thank you so much, Linda. And thank you everyone for joining us tonight. So my name's Myles. I am a registered nurse and credentialed diabetes educator. I work with Diabetes Tas. I've worked in various other roles at the hospital as well. And I'm just going to focus in this talk on type 2 diabetes and the principles of self-management. And what we mean by that is just point out some of the resources that are available to you working in primary care or community care to support you, to help you support your patients. Just a quick outline of what we can do. I will start with a quick definition of type 2, just to recap on that. Because it's topical, through some recent media coverage, we mention remission in type 2 diabetes and what that means. Cover a bit of self-management and what that means, and then some pathways and barriers to self-management, what we see in trying to help people with type 2 diabetes. And then some key topics and resources and a little bit of an idea of what we do and how we can work with you in supporting your patients. So what is type 2 diabetes? Really, it's a relative decline of insulin, and it's often in the setting of insulin resistance. So what that means is we see people develop, probably most likely develop insulin resistance first. That is, your body's sensitivity to insulin isn't as good as it used to be. And so your body needs to make more insulin to overcome that insulin resistance, and that pressure in the pancreas can cause insulin secretion, or the amount of insulin your body can make, to decline over time, especially if we do nothing. So with that relative decline of insulin, we see hyperglycemia. Now we get the acute side effects of that, or the acute presentation of that, which is being thirsty, tired, because you're not getting your energy, and increased urination, sometimes poor wound healing, all those things. Blurred vision can occur if your sugars are really high. So you might see that. It's not very often in type 2 diabetes. It's quite a silent condition if that insulin hyperglycemia develops fairly gradually over time. So those symptoms of hyperglycemia are non-specific. And so people often will write off being tired as just being too busy or getting older. But we do know that there are chronic side effects of hyperglycemia, and those the damage to the microvascular parts of your body, like in the back of your eyes, so affecting your eyes, your kidneys, and your feet. So we know that over time, that chronic hyperglycemia can cause poor health in increased morbidity and even mortality, which is why we're interested in preventing or supporting people to live well with diabetes. On the right, you'll see there's a little bit of a guide, which is a really handy tool from the NDSS. which is free for you to use, a really nice teaching tool, example of a quick guide that you can use with the icons to talk about what I've just explained. So a really handy tool you can use in your own clinics to get people to understand what's going on in the bodies. And it's usually the first step to self-management, is giving that knowledge and understanding that this condition is quite complicated. There's a lot going on in their bodies that will explain why we do the certain treatments we do, or why some treatments might not work over time. So what does we did cover last week how we diagnose diabetes, and we're looking at hemoglobin A1C, or glycated hemoglobin, is the main pathology test we use. Anything over 6.5%, which is different from millimoles per litre, it's different from a finger prick. So when we talk about remission, Diabetes Australia have just released this position statement on remission. Because it's been quite topical, there's been some big research studies, notably out of the UK, where they've seen people go from a diagnosis of diabetes, that is an A1C over 6.5%, to under 6.5%, and they stay there without any medication. So that's the general definition of remission that's come out of that research. So reduced A1C to below diagnostic level, and staying there for 3 months at least without any medication. Now, to achieve remission, most of these people have had to lose 10 to 15% of their body weight, either through bariatric surgery or through very intense diets supported by, some meal replacements supported by dietitians and full teams looking after them. What we see is most people, it's effective for most people. They've been diagnosed for just under 2 years. And usually it's people who have that high insulin resistance. So we see people with who are overweight or obese. It's more effective, it's more likely for them to go into remission. What's important about remission and talking to patients about remission is that it doesn't work for everyone. It's and this is because the type 2 diabetes is quite a complex condition. It's quite different from person to person, and certainly over time, if you've lost beta cell function, if your body's not making its own insulin, you're less likely to be able to go into remission. So the research would put it in a more positive light. At least a third of people can go into remission, and we should certainly try. If we get someone early diagnosis, early in their early part of their diagnosis, certainly something to look at. But just to be mindful of setting people up the expectation that they should go into remission, because it can be quite hard to achieve, and not everyone gets there, and it may not last more than a year or 2 years at this stage. And we're not sure how long remission would last for. So it's certainly not a cure, and so we just need to be mindful of that. And I'd encourage you to have a look at that position statement. So we talk about type 2 diabetes as a chronic condition. So we follow this, the American Diabetes Association recommends following this chronic care model, which has 6 points of care. The thing we're interested in is self-management support, which is the work, the hands-on work that we do. Being mindful that the person with diabetes lives with it every day. We might see them once a year or twice a year, or maybe a bit more frequently early on. But they are living this every day. They are dealing with it every meal sometimes. There is still stigma attached to type 2 diabetes, so it's not an easy condition to live with for many people. So we really are aiming to support self-care through behaviour change and that transfer of knowledge and skills. So knowledge to make informed decisions and to have realistic expectations about their diabetes, and also the skills to be able to monitor their diabetes through change, through life changes, and so they can make the right decisions around treatment when treatments need to change, if they need to change. So it does take a team to look after someone with type 2 diabetes, and that's why we're really keen on sharing resources and trying to unify messages across the healthcare network so that we're all sort of singing off the same song sheet, because people do find there's a lot of information to learn and it can be quite confusing. Just waiting for, there we go. So it's useful just to think about what's it's very we talk about teaching people self-management, but and there are things that work and there's sometimes things that don't work. So some of the pathways for success are making sure there's access to health services, so when people are diagnosed, they actually can get in touch with diabetes educators, dietitians, the GPs, exercise physiologists, and that those members of the team are able to collaborate and care and share decisions with that person. Really big, and you saw in that chronic care model, on preventative or anticipatory care, even when you're diagnosed, setting targets and goals of care, really, and smart goals, making them quite measurable and simple, and helping and making them shared targets, so that the person can have something to work towards, rather than waiting for things to go wrong and then trying to catch up. Multidisciplinary care, so making use of the multidisciplinary care model, specialists when you need them, allied health, including social work and psychology. We found that that's really an essential part of managing people with diabetes in our line of work. So conversely, the barriers to self-management, lack of access to health services. So the cost and geography, in Tasmania, there's quite remote communities. And so getting in touch with people, even getting into GPs at the moment can be quite tricky. Language and literacy, we need to be mindful about health literacy as well as literacy, and making sure we're using resources and language that is common to the people we're talking to, so that the information we're trying to convey translates to their particular context. Treatment inertia, we see that a term used in primary care where people are sitting, not wanting to progress in their treatment or do anything about things because they might have other things going on. A1Cs are going up to 8 or 9%, and they sit there for a good 12 months before they finally get motivated to do something about it. So that's not ideal, because all that time sitting above 7% of an A1C is causing that microvascular damage. There's other things, barriers, the social determinants of health, which we need to be mindful of. So environmental and psychosocial challenges, economic. It's very, we know that it might be better to change someone's diet, but if they can't afford those dietary plans, or they've got other priorities, emotional or psychological priorities, then you're not going to be pushing some of those lifestyle changes, or not very successfully anyway. So really helping people identify what those barriers are and maybe dealing with them first through referral pathways. So there are some key topics and resources that I would point out, and we'll put the links up in a sec. As I said in the beginning, really giving people a clear understanding of their diabetes, and there's nothing wrong with just giving it in small chunks, explaining it, and demystifying it as best you can, because everything you explain in understanding the disease background or process, the pathophysiology, supports then all your decisions around how you're going to manage, or how they're going to manage their diabetes. So they're getting that early understanding, and reinforcing that as often as needs be is important. Nutrition. There's no prescribed diet for diabetes. We talk about nutrition the same way we might talk about nutrition to other people. The focus is obviously on carbohydrates, because they are the things that most obviously push glucose levels up. But we certainly wouldn't be advocating for any special diets at this point, just really helping people to navigate the world of nutrition, and that can be a full-on job. So thinking about dietetic referral. Obviously activity, and that's not joining the gym and becoming a sports nut. Really, for a lot of people with type 2 diabetes are much older. They might have chronic pain or other conditions that are restrictive for their activity. So it's just about encouraging them to be active in other ways. And they might need referral to exercise physiologist or physio. Teaching monitoring of glucose, sick day management, rather than, so giving people the tools to understand that when they do get sick, that their blood glucose levels will be affected, and there are things they can do about that to prevent them getting worse. Obviously hypoglycemia management, and that's in the context usually of if they require insulin or they're on a sulfonylurea, so dimicron, where they're at risk of a hypo. So really education around that, how you can treat it, how you can avoid hypos, and how you can be safe around driving, for example. Medications, so medications are important, and there are a lot of new medications around, so there are some guides around that. Non-insulin injectables, the once weekly ones, incretins, and insulin, obviously. So just on the right, you'll see those, when you see those on those links on the guide. So just the top, the information, the NDSS has not only information resources on a lot of those topics, but also in other languages. They also have a diabetes management in aged care, which we helped develop, which you will find on their website. That's more for health professionals or people working in aged care. And then we have on our website the diabetes quick guides, which cover those topics I've just mentioned on the left. So really handy resources with links to further resources as well. So please have a look at the links and use them in your practice. I'll just quickly highlight that the Australian Diabetes Educators Association has put out some pathways. So just, this is a typical, what's the expectation in managing and teaching someone to self-manage? So the GP appointments, this is a newly diagnosed type 2. The expectation of us, this is just a framework or a suggestion, I suppose, but you can see there's a lot of contact points for education early on. And there is a tendency in primary care for people with newly diagnosed diabetes, especially if they don't require treatment early on, to A, not register them, and B, not refer them for education. I think it's really important that we do get in early, that we give people the tools so they can anticipate and understand what's going on, rather than, as we've said before, waiting for things to go wrong. So a little bit of education early on can go a long way. So those are available on their website at EA, and PDFs are free. There's also one for starting insulin as well. I'll just quickly run through, just mindful of time. We've got one of the quick guides in front of you now. This is just a couple of pages that are really useful for talking about monitoring blood glucose. We're going to talk about sensor glucose monitoring later on. So this is just a really useful way of describing that we monitor through regular HbA1c, so three monthly, 6 monthly if they're stable, to a target, usually 7% for an independent adult, slightly higher as for older or frail people. Daily self-monitoring, so that's the finger pricking that we're all sort of familiar with. And now, of course, there's sensor glucose monitoring, which is really directed for people on insulin. And there's a cost to sensor glucose monitoring, which we'll talk about later. Really being clear, this helps you describe how, we have what we routine monitoring, who needs to monitor. Generally, we would encourage anyone who's at risk of a hypo to monitor. So it's mostly people on insulin or on a sulfonylurea. People who choose to monitor, they find it's useful for them, but just be mindful that monitoring can also cause stress. Some people really don't want to know what their blood glucose levels are, especially if they can't do anything about it. They're not taking insulin, they can't correct it. So routine monitoring, there are times we would usually do a fasting one when you wake up. You would routinely monitor before a meal, or at least 2 hours after a meal if you wanted to see the effect of that meal. And occasionally it's good to check overnight to make sure there aren't any dips or hypos overnight, especially people on a basal insulin. There's a table to guide you to discuss about how often that routine should be. So for, quite commonly people are on a premixed insulin, so you'll see the third, fourth box down. If you're on a premixed insulin, you're checking both insulins. You should definitely be checking before each injection. But if you wanted to see the effect of the rapid acting component, you would check 2 hours after. And if you wanted to check the basal component, you'd be doing your fasting in the morning. You might be doing one just before bed, and maybe occasionally overnight, especially if you change the dose. That's a guide for you to see, okay, maybe 2 to 4 times a day, that's routine. And then there are times when you would teach people to do an extra finger prick. If they're on insulin and driving, they've got to be 5 to drive. If they've had a hypo in the last 24 hours, doing a few extra checks to make sure they're safe. Before and after extra activity, and that again can just be as simple as doing gardening, going out to chop the wood, making sure people are monitoring, doing a few extra checks then, and keeping hypo treatment with them if they are at risk of a hypo. Sick day management is a big one. So teaching people to, and there's a guide on this in the quick guides, but if people become sick, then the stress response to that, pushes their blood glucose levels up, so increased monitoring, keeping hydrated. If they've got vomiting and diarrhea, obviously that they might actually go down. So making sure they hydrate with fluids that have got glucose on, for example, keep them safe. And of course, doing any extra, if any concern or any sign that their diabetes is progressing, you do some extra checks as well. Just a quick final slide on what we do as a Diabetes Tasmania, that you can always refer to us. You can refer through as an allied health referral, the GP referral, so your GPs can refer directly to us. People can self-refer to us. We will offer, we will triage those referrals. You can refer anyone with pre-diabetes, type 2 diabetes. We would encourage anyone with an HbA1c over 8%, or if they're newly diagnosed, certainly refer into us. It doesn't come off their care plan. We will triage them into the appropriate health professional or group, so we can give that education, and then we communicate with the GP. So if we get a referral from you as a nurse or from the person themselves, we will then, with their consent, get the medical history from their GP, and then we'll communicate with the GP from there. As I said, it doesn't come off their care plan, and the referrals are on our website. You can do it electronically, directly from our website, or they are available, the GP referrals available in your practice software, it should be. So that's it in summary. If you have any questions, please feel free to post them in the Q&A function. If not, and you can do that anytime really, we can answer them as we go, or come back to them later. But hopefully you'll find those resources useful, and I will leave it there.
Thank you so much, Myles. Yeah, it's a great opportunity to always refer clients and patients on to Diabetes Tasmania to get some support. So yeah, like what Myles was saying, if you have any questions, just post them in the Q&A and Myles will be around to help answer them. Otherwise, I'm going to hand over to our next speaker, Elisa, who will talk about some practical tips around insulin. Over to you.
Thanks, Linda. Hi, everybody. Yeah, I work in the Devonport office of Diabetes Tasmania, and I'm really happy to be talking about insulin and talk about some practical tips. It's actually 100 years since Banting and Best were able to work out how to extract insulin from a dog and inject it into another dog and to keep that dog alive. And that was 100 years ago. So internationally, everybody is having celebrations about that, which is great. As you can see from the picture, prior to 1921, it was a dire consequence if you were diagnosed with type 1 diabetes. In 1923, insulin became available to as a commercially available product. Today we have a variety of different insulins available. We have our background insulins. So we've certainly moved on from the old days of Protophane only, but Protophane is still available. Just to note that Semiglee will be disappearing from the market at the end of this year. And Opticiolin is a new version of Lantus, basically from Sanofi. Lantus is not on PBS now, so everyone is moving over to Opticiolin. And Toujeo is 3 times stronger version of a background insulin. So it's particularly helpful for people who have a lot of insulin resistance and need a bigger dose. So they're basically getting a much smaller volume to get that dose of insulin administered. We have moved from having insulins such as ActRapid to more ultra fast acting insulins available now for boluses. And so we've still got NovoRapid, Humalog, Apidra, and now Fiasp is relatively new. So it works immediately. Just something to be aware of is that we are seeing quite a few people having their insulin after meals, but quite a lot after their bolus, quite a long time after the meal. So they're running a big risk. So they're waiting 2 hours and injecting. So just to highlight that and to keep an eye on that, they are actually administering at the correct time. But the background insulin can be given anytime, and it's not meal related, but it needs to be at a regular time. We have our premixed insulins that we would most often prescribe for people living with type 2 diabetes, depending on the person. We still have Mixtard 30 available and Mixtard 50, but then most people we would see would be using something like Novomix 30 or Mix 25. And the new kid on the block is Ryzodeg 70, which is the rapid-acting insulin in a formulation with Deguladeg, which is an ultra long-acting. The beauty of that one is that it can be given once a day with the main meal with carbohydrate. And if that main meal changes tomorrow, they can actually move it to that time. So it's flexible and it's very reliable in its action. I think when you're starting somebody or talking to somebody about starting insulin, it's really looking at the person, looking at their blood glucose profile and picking the right insulin for the person, if it's keeping it simple or whether they would be better to have 4 injections a day, but having a conversation. And it's also really important to actually start that conversation about insulin early. As Myles was talking about, we have that treatment inertia and how important it is to have for the person living with diabetes to actually understand their diabetes well. It's really not helpful to use insulin as a threat to say if you don't basically behave yourself, then we'll have to give you insulin. That really isn't empowering for the person to actually work towards self-management. So they really need to understand what they're doing, what their targets are, and that there's an amount of insulin and medications available before moving to insulin. And I guess one of the things that we will perhaps find a little bit easier is because we have GLP-1s now available, more people are willing to take a once-a-week injection, and so moving to insulin after that isn't such perhaps a daunting thing as it was before we had GLP-1s available. So having that conversation, highlighting that it's not a failure on the behalf of the person, as Myles has mentioned, it is progressive and you can do everything, and sometimes you will need insulin. Some people need insulin really soon in their journey with diabetes and other people may not need it, but we do know that the longer you live, the more likely it is that people will need insulin. I'd highlight the benefits of why somebody should start insulin and start it when they're above target, but not waiting. Don't, some people come in for years saying, oh yes, but I will make some changes and talk about it next 3 months, but that can go on for years before it actually before usually a crisis hits and they're agreeable to having insulin. So it's not a failure on their behalf. But if they start, they feel better, the sugar level's lower, obviously, they can have more energy because they have got more lower sugar levels, and it's actually quite safe. And for some people, it's cheaper if they reduce some medication to go onto insulin. It can work out to be a cheaper therapy as well. Demystifying the insulin pens, what they look like, can be really helpful as well. What size needles we use. I'm sure a lot of them think that they're long intramuscular, like the COVID vaccination needles we see every day. And that everybody's requirements are different as well when they're starting. So that little booklet that I have got up there, that's available on NDSS, and it's a workbook. they can take it home, go through it and work out why it might be best for them to start insulin. So not only do you need to think about what insulin suits the person, but what pen device. And so there are quite a few different options available for the person. I really like using the innerlet if somebody has weakness in their hand, say a stroke or arthritis, or low dexterity in the hand, so that they can use to hold a little bit easier. It leans against the stomach, and the broad base helps to stabilise when they're actually pressing the plunger in. It does only go up to 50 units, and it's only available in mixed hard 30 and Protophane, but it's an option for some people if they need insulin. We have the non-disposable pens like the Nova Pen 4 and Clickstar for Sanofi insulins and Humor pens for the Lilly brand. So they're still there, but most people tend to take the option of a disposable pen like a Flex Touch or Flex Pen. You've just got to be careful if you're the prescriber that you're picking the right insulin and not vials if they need disposables. So it's just being careful with all the drop downs when you're choosing it. Ryzodeg is a shorter pen, and one of the things that's quite handy is that when you dial, it doesn't dial out, it just dials up. So that's handy for handling it and easier. And I just squirted the wall with some insulin, but it's really smooth in its delivery as well. So that's another thing to think about. I did put in there to highlight Timesulin. That's a little cap that people can purchase online just under that brand name. It costs about $25, but that little cap goes onto the pen, and then it will, if somebody takes it off for more than 8 seconds, then it will actually count that as a time of administration. So they can refer back to see when they last had their insulin, which is really handy as well. So there's different types of pen devices depending on the need. When people are starting insulin and you're talking to somebody about injecting, it's important to show them where the best spots are to inject. We would usually recommend the stomach as the first option because it's stable. If somebody's really active, then the thighs wouldn't be the best choice, but it might be a spot that they could inject if they're on 4 injections a day of an evening when they're less active. And the arms can be used, but they're really tricky. So it would be a parent perhaps injecting a child as another option to inject. Absorption of insulin can be altered by different factors. So if you're really hot, it can increase the absorption. If people have their insulin in the morning, it's best to have the insulin after the shower, or after the bath, not before, because that's going to speed up the metabolism of the insulin and can cause hypos as well. Exercising, as I mentioned, if you massage the site, that will move the insulin quicker, and injecting intramuscularly will mean that it will absorb much more rapidly and can cause hypos. So what we actually do know is, what I know is back when I started my training, and for a long time we used 12.7 millimeter needles. So basically double what we use now. But what they've done internationally is looked at the depth of the subcutaneous layer, and it turns out that no matter what weight you are, that most people's subcutaneous is never more than 8 millimeters. So back in the day, we were obviously injecting into muscle layer a lot more than we weren't. And so now even 8 millimeter needles are not recommended for most people. Probably if you're over about 140 kilos, then you might consider the 8mm needle. You can see from this picture what hypertrophy looks like, as well as bruising, and that's caused by when people are injecting into the same spot all the time. And I know when I demonstrate to people, I know I would tend to go to the same, go to the same spot. So really really highlighting that they rotate around to avoid doing that. If you've got people coming in, always when you're doing a diabetes check, look at the injection sites to make sure that then they're not getting anywhere near this kind of size lump. If they are injecting into that area, what you would see is really erratic sugar levels. And we know that some of the insulin, the absorption rate can vary up to 85% different on any day with those different things that I mentioned. But injecting into this kind of spot will be significant in altering the effectiveness of their insulin. And if they move from injecting into that spot to another site, then they run the risk of having a hypo with that higher dose. So if you spot something like this and they have been injecting only into that spot, you'd want to reduce their insulin by a percentage, probably 10% when you tell them to move on, because they run the risk of having a hypo at that point. Just check that that they are changing needles every injection, not every month or at the end of every vial. So make sure they're doing that and how often they are changing sites. Don't inject into scars and stretch marks, and make sure that they pinch up. If they do are slimmer, they can do a broad pinch up to inject. So storing insulin, there's a few things to make sure that people are aware of. The insulin that's not being used must be kept in the fridge, but be careful that it doesn't get pushed, that they don't push it to the back of the freezer. I've had people come in, their sugar levels have been have changed, and it turned out that they had accidentally frozen their insulin at the back of the fridge. Or they've left the insulin in the car over the weekend and used it, it will go off. So it's okay to be used at room temperature. That the one they're using can stay at room temperature for 28 days, and that's fine. So they can pop it in their handbag to go shopping without putting it in a cooler bag, that's fine. But as long as they're in reasonable temperatures, that room at under 25 degrees. And yeah, as I said, that lasts for 28 days. So insulin is well tolerated. I think in 25 years, I've seen 2 people. I've met one and heard of another in Tasmania who actually had an anaphylactic reaction to insulin. And they were treated by insulin pumps where they can have a tiny amount, and they said that they cope with that with other medication to keep antihistamines. So that's rare. Some people get a rash around the site, and if that was particularly bad and they were on, say, a mixed insulin, or you could try them on a different brand of insulin with a different preservative, and that can work to if it's bothering them to have if the rash doesn't settle down. But the main problems with insulin are more around the fact that you run a risk of having a hypo if you have insulin. If they are out in the garden and too busy to come in and have lunch, they run the risk of having a hypo. If they don't give themselves enough insulin, they're going to go high. And things that can cause high sugar levels that mean that their insulin requirements change could be infection, illness, exercise, diet. So people need to learn how to look at their trends in their sugar levels, not reacting to every change, but to look for trends and make adjustments. So that some people can be taught how to make those changes. Stress can affect sugar levels. I often say stresses like drinking a can of Coke, it can affect you that much for your sugar levels. So identifying what's causing the stress, from working towards improving that, and hormone changes as well. And just to highlight that, as Myles mentioned, we have insulin, a guide to insulin as well in our quick guides that you can link to. And within that, there is a little digital web animation, a little digital about insulins and how to inject that you might use when you're talking to somebody about starting insulin. Yeah, if you've got any questions or any time, just contact Diabetes Tas.
Thank you so much for that, Elisa. It's pretty crazy to think it's just been 100 years with insulin and how different it was before that time.
I know. I actually remember when I was probably about 5 and my grandfather was type 1, and I used to play with the insulin glass syringes that my nan kept in the shed.
Yeah, what a difference to see that happen in such a short period of time.
Yeah.
So thank you so much for that, Elisa. If anyone has any questions, feel free to post them in the Q&A. Elisa will be here throughout the rest of the night. And our next speaker is Myles. So I'm going to hand over to Myles to talk about the flash glucose monitoring and also a bit of a demo at the end.
Thanks, Linda. Thanks, Elisa, as well. So it's timely. Obviously, insulin it's one of those treatments that we use. It's the only treatment we can offer as a second line, third line treatment. So sometimes starting insulin sooner rather than later is useful. But in order for insulin to work, we need to monitor it. And I'm sure we've all heard of the fact that I mentioned it before. Finger pricking can be quite onerous. It's quite painful for some people. So we do have new sensing available in this country and overseas. So continuous and flash glucose monitoring is what I'm going to be talking about, and hopefully get time to do a quick demonstration of a couple of them to give you an idea of what's involved in setting people up on the monitor. So we'd really thinking about people on insulin. We wouldn't be talking about this technology for people who are not on insulin, basically. So what is continuous glucose monitoring, or CGM? Basically, it is the insertion of a sensor that sits just in the fat layer, and usually on the abdomen, but sometimes on the back of the arm. That sensor takes a reading of the glucose in that interstitial space every 5 minutes or so. It's connected to a transmitter. That transmitter collects that glucose data. It sends it then to a device. So that receiver or device can be a phone, can be an insulin pump in the case of type 1 diabetes, and there are blood glucose readers as well that'll do it. So there are a couple of continuous glucose monitors available in Australia, and I'll talk about them in a sec. What's really useful about this, and what you'll see is it's fewer finger pricks, and we'll talk about it in a second. But having a sensor take a reading at up to 200 times a day, we start to see trends, and you can. And these devices have an algorithm in it. So not only can you see where you've been in terms of that graph. I'm just going to put the highlighter on here so I can point to things. So, and we'll see this better in the next slide, but you can see so I can see how I was traveling overnight. It gives me the reading where I am now, but we also see trend arrows in all the devices, which is really handy. So a 6.1 going up is different from a 6.1 going down, and has implications for my treatment decisions. So this is one of the devices available in Australia at the moment. This is the Medtronic G3 sensor. So I'll go through this with the other ones, but usually what you've got is the sensor that comes here. You've got the transmitter here, which is actually on a charger. This one has a battery in it that you charge, so it lasts up to 12 months. In the pack, you'll get some alk swabs so you can clean the site. And this tape is to go over the sensor once it's inserted. And this little device here is the inserter. So you would basically place that sensor into the inserter using that green button, would then deploy that using a needle that sends the sensor under the skin. And then it usually, for most of them, you half an hour to an hour for it to warm up before you can then start doing your first read. So this one goes over to a phone, and you can see what the display looks like. You've got 2 arrows going down and a reading of 5.9, and you can see the trend, and you can break that out over 3 hours, 6 hours, or 12 hours, I think. So this particular device lasts for 6 days, so you have to replace the sensor every 6 days. It's inserted on the abdominal flanks around the side here, where you could inject insulin. And obviously, once you're wearing one, you wouldn't inject within, I think it's about 7 centimeters of a sensor. It does need to be calibrated, so that means you need to do a finger prick at least twice a day just to calibrate the device, because so it can then relate what it's reading in the interstitial space to the blood glucose level reading as well. This is the other brand that's available. AMSL make this. This is the latest version of their Dexcom G6. So this device just comes, the actual sensor is housed in this disposable inserter. The transmitter is quite small, and it doesn't need to be charged, but it only lasts 3 months, and then you have to replace it. It does last for 10 days, so it lasts a bit longer than the Medtronic one, and it doesn't need calibration. The previous iteration, the G5, does need to be calibrated. The G6 doesn't require calibration. And again, it's worn mostly on the abdominal flank. So that's just a display. It goes to a phone, and it can be followed as well. So for parents following a child, they will get, through the cloud, they'll be able to monitor the child's glucose levels. And their arrow system, you can see it goes red when it's got low, and there's a double arrow going down. It looks like a bird beak, and an arrow going up showing it's trending up. So the other type of sensor available in Australia and overseas now is the flash glucose monitoring. So flash glucose monitoring is again a sensor that's worn. It sits in the subcutaneous, in the interstitial layer, takes a reading every 5 minutes or so, and the reader is either a glucose reader, or it can go to a phone. And the difference with this is it does not transmit the information directly to the reader, and it cannot transmit it to an insulin pump. So you have to actually scan the sensor for it to upload the information. So it stores the data for about 8 hours. So you have to scan at least every 8 hours to get all that data. But again, using your a smartphone, you will still see the same information in terms of your current level, your trend arrow, and your historical pattern. And so the Libre is the only flash glucose monitor around. They've just released the Libre II this year. So the Libre II has the advantage that it now can alarm on low. So it can actually, so if you've got your phone in your room with you while you're asleep, and your levels are trending low, it will actually, your phone can then alarm, and you can set that level wherever you would like it to be. It can alarm on high as well. It won't tell you what you are, it'll just alert and buzz and whatever you want, if you want it to make a noise or just vibrate. And then what you'll need to do is scan, and you'll see where you are. So that's really handy. It's a little bit more accurate, and these last for 14 days, and they do not need to be required, they don't need calibration. They are only worn on the back of the arm. So the flash system is not accurate, worn on the tummy or the flank. What's handy for us is the reports that can be generated from all that data that's being collected. So this is the Medtronic version of that data. What we're really trying to look at is it starts to give you an average glucose profile. So we can see an average trend. You can see that middle line with the standard deviations, the 25th and 75th percentile. And then you can see also time in range. So you can set that range, whatever bracket you want it to be. And over whatever period, that 6-day period for the sensor, it'll start giving you that information, how many hypos, and you can start seeing where those hypos are. So the AMSL, the Dexcom one, looks a little bit like this. They report it slightly differently, but it's the same information. You can also record your insulin doses through the apps as well. So you can mark off when insulin was given or when a meal was given and when exercise was done. So that can be helpful. And this is the average glucose report, just the front report for the Flash Libre as well. Again, just highlighting, I can see that for this person, I'd be very interested to have a look at what percentage of time they're having lows. And then I'd be looking at the trends, where those lows might be falling. And that would inform, be very useful in terms of adjusting their insulin doses accordingly to keep them safe. So sensors are not cheap. And they are subsidised through the NDSS CGM initiative. Now, they're only subsidised for children under 21 years with type 1 diabetes, so they can access CGM, and that's quite useful. For a lot of them will be using insulin pumps, so they're quite handy because the sensor will talk to the pump directly. Women with type 1 diabetes who are actively planning pregnancy can access subsidised sensors as well through that pregnancy period and post-pregnancy. Children with conditions similar to type 1, so usually that's referring to cystic fibrosis diabetes, and generally if they require insulin, then they can get access if they're under 21. Recently, or most recently, people with type 1 diabetes over the age of 21 years who have a valid concessional status, and also if they are Aboriginal and Torres Strait Islander background, can access the subsidy. Now, that application form has to be signed by an endocrinologist or physician or specialist in diabetes, nurse practitioner, or a credentialed diabetes educator. And then that system is delivered to the patient and the first setup has to go ahead. So just from a primary care point of view, if you've got someone who can afford a sensor, if with type 2 diabetes, they're on insulin, they might just want to use it occasionally. A flash glucose monitor, for example, worn for 2 weeks while you're making changes to insulin doses. They can order that online, or they might not, if they've got type 1, they might be able to get it subsidized, but they can order it directly, and then you can help set it up, or you can refer them to us. We can do that first teach, or we can support you via video link to do the first teach as well. So I'm going to ask if we've got time, we've just got 5 minutes, I'll do a quick demo of, I've got 2 devices with me. I'll certainly put some questions up as I go. For any of these devices, they've got their own really good insertion guides, videos, and booklets. So if you do have one, you don't need to remember this, but you can certainly watch that with the patient and go from there. So I've got here, the first thing to know is that if you're going to use a sensor device, it will have to link to a smartphone for most people. So you need to check on the website of the brand what compatibility the device is. There are some phones that don't. One of the simple ways to check is to ask the patient to go ahead and download the app. So each device will have its own app. They download the app, which is free, and then they'll have to set up an account through that app prior to their appointment. If they can't download the app or it doesn't work, then you know that that phone's not compatible. Most of the companies will list the kinds of phones, usually an iPhone 6 or more recent, and Samsung are your safest bets. So the first thing you want to make sure is they've got the compatible smartphone, and B, that they've got downloaded that app and opened an account. So they've set up their account. So this is the Dexcom device. As I said, this is the G6, comes its housing. Before you open the package, just make sure it's in date. There is a code there which when the person's smartphone will walk you through the steps, and you'll scan that to register that device. So keep the package handy. It does have a little QR code there you can scan as well. So you'll notice that the device is housed in here. This tape will come off, and that's what's going to stick to the abdomen. I'm going to use this as my abdomen. And I've got a transmitter here, which is really tiny. And that has little contact points at the back. which you may not be able to see in my camera, but those, if it's the second time, those just give them a wipe with, if it's been worn for 10 days, given it a wipe with an alk wipe, just to clean that contact point. And again, that lasts for 3 months. So you'll have an alcohol wipe. So again, it's recommended that we insert this on the abdomen. So choose your site, usually where it's not bruised, anywhere, on the abdomen between, away from bone, away from scars and that sort of thing. What you're going to do is peel off the paper tabs. They come off. Now that part's sticky. You'll hold that against the abdomen. I'm sure it's going to stick as well on this. So once you've got that secure, you're going to just loosen this safety catch, because that's going to then free the release button for you. Holding it nice and firm against the abdomen, and you're just going to click that. And what it's going to do is it's almost like just being punched lightly. You don't really feel the needle. Once that's done, that needle is then housed in there, so that's going to have to be disposed safely. And what you'll see, what's left on the abdomen is this sensor casing. So you just make sure you'd run your finger around and make sure that's stuck. Most people would wear it that way in portrait rather than that way, because you bend in the stomach, so make sure you do it that way. This little device has a foot, and it's shaped narrow to large, so you're going to insert that. This is probably one of the hardest, but you insert that foot, and then you're going to press it down and just make sure it's clicked in all the way around. At that point, you're going to go to the phone device and just press and start sensor. And that will then use Bluetooth to connect to the transmitter, and it'll start a warm-up process, and then the app will guide you through the next steps, and it'll start taking a reading, I think, after about an hour or so. Just a tip that it's because of the trauma of inserting the sensor first up, it might not be as accurate over the first 24 hours. The other thing to be mindful is that a sensor glucose is slightly delayed from a blood glucose, just because of the physiology of glucose coming through that. It comes through the blood then to the fat layer. So if you're dropping really fast or rising really fast, then we'd often recommend people just do a finger prick to check where they are, because they might be a little bit lower than what the sensor is telling them, or a little bit higher. So that's that one. I know we're running a little bit late, but I will quickly show you this one. This is a flash glucose monitor. So this comes in 2 components, what I call a yogurt tub, which is the sensor, and then you've got the inserter device. So all you need to do is peel back the yogurt tub, and that's going to open up the sensor for you, and then you're just going to twist the cap. Now, just be mindful that in there is a needle. So if you've got people a bit needle sensitive, don't show them that bit, and don't put any pressure on this blue part now, because that will deploy it. Now, hopefully you'll see there's a grey line there. And if you look at the bottom of the yogurt cup, there's a grey line there, so that you line those 2 things up. And pressing it on a hard surface, you're just going to push down. And that's then going to link them up. Now that's ready to go. So before you've done that, in my rush to get this done, what you're going to do is choose a site. So I'm just going to choose the back of my arm. Now you can get people to rest their elbow on the bench. Just give that a wipe down and give it a little while to air dry, so that's nice and clean. The important thing now is you're going to place this really nice and flat against the arm. No funny angles, and you don't need any fancy moves or anything. Once you've got there, just get the person to relax, and all you're going to do is push firmly against the base of that inserter, and that's going to deploy. And again, it's really not painful at all. It's like a little flick, and that now is inserted on me. I'm going to then just run my finger around. There's a little bit of tape. I don't know if you can see it around the edge, and just even hold that nice and firm up against my hand for half a minute. Once that's done, we're good to go. On the app, on the phone, you just press start sensor or start new sensor, and you can do your first scan, and then it'll start that 60-minute warm-up. And after that 60 minutes, the patient will get a reminder then to do a scan. So those two devices, the third device, the Medtronic one, I don't have with me, but it is a similar process to the second one, in that you have to you get the inserter and you put the sensor into it, and then you'll deploy that onto the abdomen just by pressing a button. And then you just pop the sensor on the transmitter into that casing. Probably more common to see flash glucose used in type 2 diabetes with people in insulin. I'd really like to see people using sensing in residential aged care. I think it'd be very handy for frail elderly people, especially if they're on insulin. So look, I'm a bit of a rush, but hopefully that's giving you an idea of what they do, what they look like. And if you're interested in them, if you've got patients you think would benefit and are interested in going onto sensing, refer them to a diabetes educator if they haven't already seen one, to have that discussion and to see if it's suitable for them. Thank you very much. I will leave it at that. If there aren't any questions, I'll hand over to Linda again.
Thank you so much for that, Myles. So the last thing that we have for tonight is just making sure that you get a chance to fill out our survey. So this is the first time that we're running webinars in this kind of format. So please do take the time to fill out the survey of tonight's event. It's just been posted in the chat. It's a really quick one. And again, thank you so much for joining us tonight. If you do have any questions from tonight's event, please feel free to contact us. You can contact us on various methods, and of course you can always Google Diabetes Tasmania. So that was everything from us tonight. Thank you again for taking the time to join us, and we hope that you will all have a good rest of the night.